Yeah, hi winners. This is Dr.Srikanth from Team MDS CONQUER. Now I'll be talking about the first and foremost important topic in your oral surgery. Okay, that is your exodontia and in detail about impaction. Okay, so I'll be focusing more on the contents or the topics where the NEET and INICET is focusing, and I'll provide you as much references as possible, and I'll include as much diagram based stuff as possible in this session. So coming to the contents, like I don't want to discuss all the basic stuff of like definition and everything you're well familiar with. And the most important area where the questions are being thrown is the contraindications of extraction. So if you go to the contraindications of extraction, it is basically of two types, that is absolute contraindications and relative contraindications. So absolute contraindications are the conditions where you should never attempt or you should never do any sort of extraction at any cost. Whereas relative contraindications are the conditions where you can think of by doing some precautions. You take some precautions and you can proceed with the treatment of extraction. So what's one such absolute contraindication is hemangioma or hematoma. So any sort of hemangioma or hematoma, if you're suspecting in the patient at that particular area where you're planning to go ahead with the extraction, you should avoid it because there will be loss of heavy blood and it may lead to syncope and shock. Next one, of course, uncontrolled bleeding. In the case of like your hemophilias where the bleeding cannot be controlled. Okay, so such conditions are absolute contraindications. Or your AV malformations like your AV fistulas. In such conditions, it is absolutely contraindicated. So coming to the relative contraindications, the things that you have to make a note is, it is in the case of your acute cellulitis, or in the case of ANAG, or in the case of uncontrolled diabetes, or in the case of hypertension, in the case of bleeding disorders, in the case of cardiovascular disorders, in the case of liver diseases, and in the case of long-term steroid therapies and patient who is undergoing radiation therapy. All these are related contraindications. So make a note. They can ask you a question like which of the following is absolute contraindication, which of the following is relative contraindication among the four, is a regularly asked question for you. So the next goes is, of course, the favorite topic for most of you, that is transalveolar extraction. So other name for transalveolar extraction is, it is also called as open extraction, or it is called as surgical extraction. Okay, so coming to this open extraction and surgical extraction, where is normal extraction done, where is open extraction or a surgical extraction is done. And I hope like most of you are familiar with your normal extraction in your undergraduate level. So we need to learn like what are the conditions where you have to go for this transalveolar or this open extraction. The first important condition is whenever the tooth is showing lots of resistance to extraction. You tried, but you're not in a position to extract the teeth. Such condition, it's better to go for a transalveolar extraction. Next is endodontically treated teeth. So we can discuss about what are the changes that occurs in endodontically treated teeth. So endodontically treated teeth, there will be loss of 9% of moist in it. So okay, regularly teeth has moist in it. Okay, so whenever the pulp is removed during the endodontic procedure, your moist will be lost. That's 9% of moist is again a very, very important question for you in an endo point of view. So whenever the moist is lost, the teeth is going to become brittle and it is more prone for fracture. So whenever you're extracting an endodontically treated teeth, you should be very careful because the teeth is very brittle. And second thing, it's better to go for an open extraction. The next is whenever you have malformations like dilaceration or like germination or fusion, which is different from your regular structure of teeth, because every tooth the movements of extraction were made in such a way that is related to the anatomy of a teeth. Okay, so whenever you have abnormality in the anatomy or a deviation in your anatomy during your developmental stage, that is during your morphogenesis. Okay, so morphological difference occurs in the morphogenesis during the growth period. So such teeth are very you should be very caution about extracting such teeth, that is dilaceration, germination, fusion and everything. And the next course is the sclerosis of bone. Okay, the sclerosis of underlying bone, in such conditions it's better to go for open extraction. And the teeth with pathologies, which includes like periapical cysts or periapical granulomas, or the cysts or the teeth which are associated with the tumors, all these things you need to be very, very careful, and you need to be very cautious during the extraction, and it's better to go for open extraction or transallular or the surgical extraction. So these are all the indications of the extraction. And of course, when you have an ankylosis, okay, when you have ankylosis, so this is a radiograph where you can see, so what is the abnormality in the radiograph? They can question you, okay, you can see the teeth was not up to the occlusal level, okay, this is the occlusal level, but the teeth was not brought up occlusal level. By seeing your periodontal ligament space, loss of periodontal ligament space, you can clearly see that ankylosis. The very peculiar feature of ankylosis on radiograph is there is no PDL space. I hope like most of you are familiar with the PDL space, okay. So you can see all these, this is PDL space, okay. So whereas in the ankylosed teeth, you don't have that particular PDL, okay. So there is a direct bond between the teeth and the bone that is called as ankylosis. So during ankylosis also, it is better to go for the open extraction. And next important, they can ask you what is the mode of treatment or what is the pathology that you can see in this arrowed way, okay. You can see this is hypersymmetries. Okay, this is, you can see this is basically the outline, but you have excess cementosis. This is called as hypersymmetries. So even in hypersymmetries case, it is better to go for open extraction, okay, or transallular extraction. They can ask a pathology related diagram also. They can simply give you the diagram by keeping an arrow, or they can ask you the diagnosis, or they can ask you the treatment plan of the case. The next comes is, okay, so before we go for transallular extraction, it is mandatory that you have to take radiographs, and these radiographs are going to help you out in coming with few conclusions. Okay, so that is called as pre-extraction radiographic analysis or pre-extraction radiographic evaluation. So what are the things that you have to see in the pre-extraction radiograph? The first and foremost important thing is its relationship, means the tooth to be extracted, its relationship to the vital structures. So how it is related to the vital structures? Because when you are extracting the teeth, it may cause damage to the adjacent vital structure. Such peculiar adjacent vital structure in the case of your maxillary teeth, when you are extracting the maxillary teeth, is maxillary sinus. So how far it is from maxillary sinus? Whereas when you are extracting mandibular molars, or mandibular posterior teeth, inferior alveolar canal, how far it is? Is it very close or not? This is a question that is given in the NEET 2020. This question was given in the NEET 2020. What are the modifications that occurs in the root on an IOPA of mandibular third molar when it is very close or when it is overlapped with the inferior alveolar canal or inferior alveolar nerve or a bundle? This is a question that is given in the recent NEET 2020. And the next one is when you're talking about the mandibular premolars, okay, you need to talk about the mental foramen or the mental nerve, because it is closely approximating and it is present between the two mandibular premolars. And how far the adjacent tooth structures? Okay, but the main consent when you are extracting is these three vital structures. That is the maxillary sinus, which is close to the maxillary first molar, inferior alveolar canal, which is close to the mandibular third molars and mandibular molars, and mental foramen, which is close to the mandibular premolars. Okay, so these are the main consent of the vital structures that you have to make a note. And you have to see the configuration of the root also in the pre-radiographic analysis, how the roots are. One is you need to talk about the number of roots, which is useful for both your endo as well as your surgery. The second one is about the size of the roots. Third one, is there any curvature? Is there any divergence? Is there any convergence? Whether roots are thin, tapered, any abnormality in the root structure, like your taurodontism, you have some abnormalities which we will be discussing in oral path. And if there is any hypersymmetries, for example, this case is hypersymmetries case, if there is any ankylosis or if it is root canal treated. So all these analysis should be done from radiographic evaluation before you proceed to the extraction. That is basically more often a transallular extraction. Whatever extraction, it is a simple extraction or a complicated or a transallular extraction, it is mandatory that you have to do some radiographic evaluation analysis before you proceed to the next step in the oral surgery department. The next comes is, of course, like I have discussed about the hypersymmetries, and this is how the overlapping. Okay, these are the mandibular molars. Okay, all these are mandibular molars, and their relationship to the inferior alveolar canal, alveolar nerve or canal. So whenever these roots are merging on this, okay, you will see some deviation in the anatomy of the canal. Okay, so that is what the question that is given in the NEET 2020, which is a repeat of NEET 2012. The same question with a different concept was given in NEET 2012, and the same question was repeated in the NEET 2020. Okay, so there are different types of anatomies, like whenever it merges, whenever it is very close, whenever it is overlaps, whenever sometimes in the case of your molars, mandibular molars, you will see the apical notch. Something called as apical notch means a notch which is present at the apical 1/3 of the mandibular roots. Okay, you can see some apical notch, some deviation in the configuration of the root outline, that is called as apical notch. So whenever you have an apical notch, it is better to go for split technique of extraction. Means, for example, if you see this, I'm quite bad at diagrams. You can see this. You can consider this as a mandibular third molar, and you can see some disturbance, something like this, some notch like this at one point. So you can predict on the radiograph that the inferior alveolar nerve canal is going through this. So what you have to do, if you blindly extract the teeth, what is going to happen? Your inferior alveolar nerve canal or the nerve is going to come out. Okay, such conditions I may feel you have encountered in your UG life. Okay, may you or your friend may extract one teeth and the patient is complaining of numbness after 2 or 3 days and it doesn't go. Okay, that can be something like that. Okay, so what you have to do in such cases, you have to go for an open technique. You have to split the teeth. So you have to remove this part and you have to remove this part separately, so they can ask you, like they can give you a radiograph where you can see apical notch, or they can give in the description part, a patient of this age entered the department upon radiographic examination. You have seen an apical notch on the root configuration, and now what is the mode of treatment that you are planning for? This is going to be a split technique. You are going to split the teeth and you are going to remove the teeth in multiple pieces. Okay, that's what the treatment plan is. The next comes, okay, this is a very better thing. Like you can see this apical notch clearly in this 3D print view. See, you can see this. This is the notch. So here it is clearly seen that your canal nerve bundle is going into the roots, in between the roots. So when you are extracting this teeth, there are high chances that this bundle is going to get damaged. So this technique, what you have to do is you have to split and you have to split and you have to operate. Okay, so that is what you have to learn. The next comes, I was talking about this foramen, that is mental foramen. Mental foramen, you can see this is present between very important points that you have to make a note. Mental foramen is present between the first and second premolar mandibular, and it is very close to, because they can ask you this also, very close to second premolar when compared to the first premolar. You can see this. Sometimes due to the variation in the angulation, you can see mental foramen as a periapical radiolucency. In this case, you can see as a periapical radiolucency. So in such case, what you have to do, you have to apply the slop technique. So once you apply the slop technique, if it is moving away from the periapical area, then you can consider it as a mental foramen. Okay, so mental foramen is present between the first and second premolar, and mental foramen is very close to second premolar when compared to the first premolar. Mental foramen sometimes may get confused with a periapical cyst or a periapical lesion. In such cases, you have to apply slop rule to rule out of it. I think you're clear until now. So we are done with the radiographic analysis also, with some diagram based and some case related stuff also. So now you are planning for like most of your questions will move on multiple extractions, or they may be on like a complete mouth extraction, full mouth extraction. So what is the, like when you're planning for a full mouth extraction, what sequence you should follow is a very, very important area and the area of questions. Okay, so first of all, you have to extract the maxillary teeth, and the mandibular teeth has to be extracted, followed by the maxillary. So maxilla is first, followed by the mandible. Okay, they can ask you why maxilla is first. Important thing is, when you extract mandible first, okay, the sockets will be open, and if you are planning to extract the maxilla, the debris or the tooth fragments or any sort of trauma can occur to the mandibular socket. So it's better to extract the maxillary. So that is due to the gravity. That's just due to the gravity. So it's better to extract the maxilla first, followed by the mandible. That is one reason. And second good explanation is, if you see the bones of maxilla and mandible, your maxillary bones, okay, your maxillary bones are porous bones. They're porous bones when compared to the mandibular bone. Okay, more cancellous bone is present in the maxilla. So whenever you give LA to both maxilla as well as mandible at the same time, maxillary teeth will anesthetize fast. Maxillary teeth will get anesthetized fast. Anesthesia spreads fast in maxilla when compared to the mandible. Okay, so that is one more reason. But the primary reason is the debris and the fragments may fall into the mandibular sockets. So the first teeth that you have to extract is the maxillary posterior most teeth. That is maxillary third molar, if the molar is present, except first molar. Okay, so first you have to extract third, second, then leave the first molar, then go for your premolars. Okay, premolars, then extract the first molar. Okay, so that's what the sequence that you have to maintain. Okay, so how you have to do, first you have to go for the maxillary posterior teeth, except the first molar, followed by the mandibular anterior teeth, except the canine. Why? Because the root surface area of the maxillary first molar and the root surface area of the canine, this we'll learn in both prosthetics as well as in the ortho, that the root surface area of the maxillary first molar is highest among the posterior teeth, and the canine is highest among the anterior teeth. So it is very difficult to extract them, so the luxation will be a problem. So it's better to extract the adjacent teeth first, then go for the extraction of the teeth, that is either the first molar or either the canine, followed by the first molar, followed by the canine, followed by the same sequence for the mandibular teeth, molar and the canine. The last teeth that is extracted is again a commonly asked question. That is the mandibular canine is the last teeth to be extracted. The first teeth to be extracted is a question for you. The first teeth is the posterior most maxillary teeth is the first teeth to be extracted, and the mandibular canine is the last teeth to be extracted. So you learn some reasons why this is extracted first, that is extracted last. Okay, so we'll move into the next level. I mean, the very important aspect is about the theories of impacted teeth. Okay, there are two theories. The first theory says that it's almost the same. It's all about talking about the size. Okay, the first theory says that as the evolution occurs, okay, the mandibular size decreases and there is no space for the eruption of the molars. And the second theory is more often like genetic based theory. Okay, what genetic based theory occurs? Okay, they talk about the two parents. Okay, I mean the child obtained smaller jaw from one parent and larger teeth from another parent. So because of which there is no space. So both these they give the same information, no space. As there is no space for the eruption of the mandibular or maxillary third molars, they get impacted. So these are the theories of impacted teeth. So the next goes is causes of impaction. Okay. So because like nowadays your questions are moving on the application based, okay, reading, retaining and just trying to expel in the examination is a pattern of approach what we have learned in the UG level, because you may not be exposed to the cases, n number of cases, or even if you are being exposed to the cases, you don't have that analysis power of thinking. Like for example, this teeth is impacted. Why it is impacted? We never think. As an intern or as a student from undergraduation level, in your OPD, what you do is you see when the teeth is not open out, you just simply says, okay, that is impacted. We don't analyze why it is impacted. Why? What's the reason it is impacted? So such application based questions will be asked in the examination. So it is a starting process where you need to think, apply what you learn, reading and application. Okay, so application part is very, very less in dentistry. We rudely go, like for example, if it is a pulpal infection, do root canal treatment, done. What root canal treatment? Okay, take working length, okay, fill the obturation, fill it, finished lines. No, we never think that why we have to do this. What is the exact diagnosis for this? What type of finish line is given in the crown? Why this finish line has to be given? So we don't analyze all these things. Someone comes, they tell something and we just follow. This is what dentistry is in most of the scenarios at undergraduation level. And I can add the same note for even the postgraduates. Someone comes, they ask you to do this, you do it. Why? The outcome is, it's a small thing, like a tooth structure is a small thing and you have braid that is 32 plus 20, that is 52 teeth you have. Okay, so no one is going to ask you if pulp is something very small, very, very small. Okay, the same thing cannot be applied to the human body. If you have some issue in the heart, go give this, do this. No, it's not possible because the patient will die. Even if a tooth is damaged, the patient may not die. So this is what the negligency that occurs in dentistry in India. But once you go out of the scope and go to the other countries, dentistry is very, very clear, documentation, okay, and you have an evidence-based dentistry and all these are there. So it's time that, like good format of exams, okay, your NEET or INACT, okay, mostly your NEET. INACT is not still updated to integrated approach. What I feel by seeing the questions or the question paper, still they're just focusing on asking the dimensions, diameters, which is meaningless at one point of view, according to me. Okay, but your NEET luckily has become an integrated approach. Okay, so most of your abroad examinations, for example, once you're done with your masters, if you're planning to move ahead to other countries, most of the inter-country trans examinations are now become integrated. Means they're going to give a clinical scenario and they're going to ask you the reason, they're going to ask you the treatment plan, they're going to tell you the treatment plan and they're going to ask you why only this treatment has to be done. So I request personally, okay, we need to update dentistry, at least from our point of view. Not in the favor of examination, but to make yourself a better dentist for the future. So let's try to analyze everything. Just try to find out the secrets behind everything. Okay. So these are the causes of impaction. They're divided into two types. One is local causes and second one is generalized or systemic causes. So coming to the local causes, the first one is obstruction for eruption. So something is coming and obstructing so that the impacted teeth is not going to come out. That is the irregularity in the position or the presence of adjacent teeth. No space. The adjacent teeth was tilted, no space. The second one is the density of overlying and the supporting bone. The density of supporting bone is not too far or not too at the point for that the impacted teeth to come out. And this is what an application based question which is given in PGA. Okay, now we don't have this PGA examination. Now everything is shifted to INICET. Lack of space in the dental arch. Okay, they have given the supernumerary in the description. So whenever you have a supernumerary teeth, the extra teeth, okay, there are high chances that the adjacent teeth may get impacted, unerupted, delayed eruption, or unerupted or impacted. And of course, we have discussed this ankylosis of either primary teeth or permanent teeth. Okay, they get impacted. They don't come out. Okay, over-retained deciduous teeth or non-resorbed deciduous teeth, they still stay, so that the the permanent teeth which is present below the deciduous is not going to come out. Your alveolar bone is very strong, is not able to resorb, so that there is no space for eruption of the permanents. Or sometimes it can be ectopic position of the tooth bud. Okay, it's not in the arch, it is erupted in somewhere out of arch or somewhere in any part of the human body. Okay, so such also, they don't come out. When they don't come out, they are called as impacted. So dilaceration or maybe trauma, no proper eruption pattern, or associated with adjacent soft tissue or bony lesions. It's very difficult. So all these are the things that you have to make a note. These are the local causes, means causes at a single point, at a particular point, at a particular tooth, a single tooth. The next comes is the systemic causes. You need to learn about few syndromes and everything where you can see more retained teeth or unerupted teeth. That is, sometimes it is hereditary. Sometimes it is postnatal. Okay, that may be due to the abnormalities like rickets, anemias, tuberculosis, congenital syphilis, okay, or due to malnutrition, or any of these systemic causes can lead to the impacted teeth. And of course, endocrinal glands are going to control lots of things in the human body, including in the oral cavity. That is the endocrine disorders of thyroid, parathyroid, pituitary, like hypo, and all these things. They have some effect on the osteoclastic activity, which is the primary culprit. Okay, where once the resorption occurs, then there is a chance for the eruption of the permanent teeth. Okay, so I mean, these endocrine things may be indirectly related to the osteoclastic activity. Some hereditary things that you have to make a note about. These are the syndromes which we'll learn at the best of these syndromes in your oral medicine and oral path. That is Down syndrome, your osteopectrosis, cleidocranial dysplasia, cleft palate, very important, cleft palate, and all these again are some of the systemic causes for occurrence of the impacted teeth. I hope you're very, very clear. All these points are important. They can convert that into a clinical scenario. They can tell you patient is having cleft palate, and they can ask you like an option related to the impaction. The next is about the classifications. Okay, so very, very important classifications. Okay, so I hope you should be very, very familiar with all these contents. Okay, so I mean, you're familiar because these are very, very important. First is Winter's classification. The second one is classification, which helps in telling the relationship of the ramus with that of the mandibular third molar. The third one is depth classification. How far, how depth it is. We'll learn about this. But make sure you practice this. Try to record this in your brain, this diagram, because this diagram is going to explain everything what is required. So first is depth classification. So what happens in depth? Okay, depth is just a comparison of your occlusal surface of second molar to the occlusal surface of third molar. Okay, so when the occlusal surface of the second molar and third molar are at same level, or when the third molar is above the level of second molar, then it is level A. The second comes is B. When the occlusal surface of the second molar, or I mean the third molar, is below the occlusal surface of the second molar, but above the cervical part. This is the cervical part. Above the cervical part, then it is called as level B. And the third one, the occlusal surface of the third molar is below the occlusal surface of second molar and below the cervical line of the second molar, then it is called as level C. Which is difficult? Level C is difficult. Which is easy? This is easy. The next classification. Next classification is ramus relationship. You can see this is a ramus. You have space. When the space is available, it is class 1. When the space is not available, half of the third molar is out and half the third molar is in the bone, then it is class 2. Entire third molar is in the bone, then it is class 3. Which is difficult? This is difficult. Which is easy? This is easy. Next, the question on difficult index. 2017 NEET, 2018 NEET. There is a question on difficult index. This question can be prepared with a clinical scenario by giving a radiograph and asking you to analyze it. One. Second thing, or by giving the description. For example, a patient entered the department. Upon the radiographic IOP examination, it is concluded that your mandibular third molar is at depth B and it is in relation to ramus. The ramus relationship is class 2 and it's a mesoangular impacted teeth. What is the difficult index? Such questions can be asked either by description or the description you have to interpret from the radiograph. They can give a radiograph. By seeing the radiograph ramus and comparing with the occlusal surface of the second molar to the third molar, and by seeing the orientation of the third molar, you have to come to the conclusion of the difficulty index. Okay, the important thing. So this is a difficulty index which is taken from Nilima Malik, 4th edition. So coming to the types, okay, that is mesoangular, horizontal, vertical, distoangular. So this is lower third molars. So the most easiest is mesoangular, it has 1 score, followed by horizontal 2 score, followed by vertical 3 score, followed by distoangular is 4 score. So the most difficult extraction in the mandibular third molar is distoangular. The most easiest extraction in the mandibular third molar is mesoangular. And it's going to be reverse in the maxillary third molars. So the same question is asked in the maxillary third molars. So maxillary third molars, the easiest is going to be distoangular, the difficult is going to be the mesoangular. Okay, so these are the important things that you have to make around. And further important thing is the most common impacted teeth is a regularly asked question. So the most common impacted teeth is mandibular third molar. The most common type of impaction is mesoangular. The most common tooth impacted is mandibular third molar. The most common type of impaction is mesoangular. The most easiest type of impaction in mandibular third molars is again mesoangular. The most difficult is distoangular, and it's going to be reverse if they are asking for the maxillary third molar. I hope you are very clear, and I hope it is very simple common sense for a undergraduate who is done with the BDS to identify the angulations by seeing the IOPA, which is mesoangular, which is distoangular, okay, which is vertical, which is horizontal. Everything can be easily done. Okay, done. Next one, we have already learned depths A, B, C. A is the easiest and C is the difficult. Scorings are 1, 2, 3. We have learned the classes, that is the Ramus relationship or the space availability. Class 1, class 2, class 3. 1 is easy, 3 is difficult. 1, 2, 3. So basing upon these 3 values, that is the type of impaction, that is the depth of impacted teeth, that is the space available for impacted teeth. You combine all these values, okay, you add them. On adding, if the value ranges from 7 to 10, this is very difficult. If it ranges from 5 to 7, it is moderately difficult. If it ranges from 3 to 4, it is minimal difficult. So they can ask a question. Okay, upon radiographic examination, it was concluded that the patient is having a distoangular teeth, which is at level B and which is at class 2 in relation to that of the Ramus. So what is the answer? Distoangular, the score is 4, class 2 is 2, and level 2 is 2, class 2 is 2. So it is 8. So if it is 8, it falls under very difficult. Okay, so such questions either by giving a radiograph or an IOPA or an OPG or by giving the description, they are going to ask you, and you have to count all these 3 parameters, add one to other, and then you have to compare with this index and you have to tell the index. Simply they can ask you what is the difficulty score. Second thing, they can ask you what is the difficulty level. These are 3 levels. Or they can ask you simply the difficulty score. The difficulty score for the question what I have given is 8. For the difficulty level is very difficult. I hope you are very clear and familiar with this. Okay, so I'm moving to the next part. Okay, hope most of you are familiar. WAR. What are these called as? War lines or winter lines, right? So very important. So what are these war lines? How to draw these war lines? Okay, and these are drawn on the radiograph, right? On the radiograph, and the radiograph of war lines should be taken, must taken by a paralleling angle technique. We'll learn about this paralleling angle, bisecting angle, what are the advantages, what are the uses in our radiology. But make a note, at this point of radiology, whenever you draw the war lines, whenever the war lines are given by a scientist, the scientist also has taken with paralleling angle technique. So you have to draw these lines on a paralleling angle technique. These are WAR lines, that is white line, this is a white line, red line, okay, and this is an amber line. Okay, so these are the 3 lines which are called as war lines. So we'll try to learn each and every line related to war lines, because war lines at one point are going to be very easy at one point the question paper or the paper setter can make the things very, very tricky. So let's read each and every line and we'll try to understand what is given in our Neelima Malik. Done, we'll move. Yeah, so we'll discuss what are these war lines in detail. So coming to the white line, okay, the first one is white line. So as we have already seen in the radiograph or the animation photograph in the last slide, that it corresponds to the occlusal line. What occlusal line? A line that is drawn touching the occlusal surface of the first and second molar and extended posteriorly over the third molar. So it's going to give the occlusal difference between the second molar, first molar to third molar. Okay, so that is something like what we have learned in the classification, that is the depth position. So it indicates the difference in the occlusal level of the second and third molar. So it's very, very easy. White line. Okay, the point to be added is occlusal difference. Okay, that is about white line. So most of we get confused between this amber line and the red line. Okay, so we'll try to read each and everything in detail. So amber line represents the bone level. Amber line represents the bone level. How it is done? A line that is drawn from the crest of the interdental septum between the molars and extended posteriorly distally to the third molar and the ascending ramus. And this line denotes the bone covering the impacted teeth and the portion of tooth not covered by the bone. So it's going to give the amount of teeth that is covered by the bone and the amount of the teeth that is uncovered by the bone, that is the amber line. The last one is red line. Okay, what is red line? Is drawn perpendicularly from the amber line to the imaginary point of application of elevator. So when you are planning for an extraction, that is impacted teeth and extraction, you are going to keep an elevator. So you are going to draw a line or a perpendicular from the amber line to the imaginary point where you are going to keep the elevator. That line is called as a red line. And red line gives an information about the amount of bone that have to be removed before elevation, because you have to remove that bone, that the line from amber line to the perpendicular where the elevator has to be applied. So when you have to apply the elevator, at that point you should not have any bone, right? So all the bone has to be removed. So what is the red line purpose? Red line is going to give an information that how much amount of bone to be removed before you apply the elevator. Okay, so these are the important things that you have to make it out. White line is going to give the occlusal difference. Amber line is going to give the amount of bone covered by the impacted teeth and amount of bone uncovered by the impacted teeth. Red line is going to give a clear-cut idea about the amount of bone that you have to remove before you apply the elevator. Okay, so these are important. The last lines are important because this was once given in the one of the entrance examination. Okay, so if the length of the red line is more than 5 millimeters, then the extraction is difficult. So red line is amount of bone removed, amount of bone to be removed. When the amount of bone to be removed is more than 5 millimeters, when the red line is more than 5 millimeters, it is called as a difficult extraction. Every additional millimeter increasing in the bone removal will increase the difficulty by 3 times. Means whenever it is, if the difficulty index for 5 millimeters is X, if it is increased by 1 millimeter, that is 6 millimeters, it is going to be 3x. If it is increased by 7 millimeters, the difficulty is going to be 3 times more difficult. Okay, so it's going to be 3 times more difficult every time when there is an increasing in the 1 millimeter. And make a note, when it is 9 millimeters, okay, it will be present below the level of apexes of the second molar. So if it is 9 millimeters, bone has to be removed. Your third molar is present below the roots of the second molar. Okay, so these lines, points are very, very, very important. So there is one more assessment. Okay, so very important. You have a question on this in your regular MCQ books. That is, the W stands for Winter's classification. Your H stands for height of mandible. Your A stands for angulation of third molar. Your R stands for root form and development. Your F stands for follicle, and your E stands for exit. That is nothing but path of exit. Okay, so do make a note. They can ask you the full form, they can ask you what is R, they can ask you something like that. So do make a note about this. And coming to, until now we have discussed about the mandibular third molar. So it is maxillary third molar. So the classifications of angulation and the depth classification are same as mandibular third molar. But there is one more thing to be added when you are talking about the maxilla, that is maxillary sinus. So whenever the sinus is approximating, okay, that is, one is sinus is approximating, sinus is not approximating. If there is no bone or a thin bone between the roots and the maxillary sinus, that is called as sinus approximating. And if there is no sinus approximating, then you will have a bone of 2 millimeters or more than. Okay, so this is an extra thing that you have to make a note when you are talking about the maxillary third molars. So next, of course, we have discussed about the pre-radiographic analysis, but we'll learn few things about the radiographs again, right, related to your impaction. So regular radiograph, what we use in the case of your IOPS is IOPA. So what is IOPA? Intraoral periapical radiograph. Okay, the reason why I have kept this is very simple. This is not called as IOPA. You have taken, but it's not called as IOPA, because IOPA is intraoral periapical. There is no periapex here, right? So this according to the norms is not considered as IOPA, and it is of no use. Okay, so this is IOPA, where you can learn so much about the anatomy of the roots and the bones and everything, right? So there's so many advantages. So when I'm talking about the radiographs, I mean, most of you know about the radiograph, that is intraoral radiograph. The choice is IOPA, whether it's a maxillary or a mandibular teeth. For example, if you are planning to extract the mandibular teeth, okay, the choice of radiograph is going to be the OPG or the lateral oblique. And when you are planning to extract the maxillary teeth, the choice of radiograph is OPG or the PA view or the Waters view. Okay, so they can ask you what are the extraoral radiographs that are advised for the mandibular teeth extraction or the mandibular molars extraction or the maxillary molars extraction. Just do make a note about this. There is something called as right angle technique. Okay, right angle technique is exposure in two different angulations which are 90 degrees to each other. So this is an IOPA and this is an occlusal radiograph, and these two are, the exposure is 90 degrees. Because IOPA is going to give you one line of alignment. It's going to give you the mesodistal alignment, whereas occlusal radiograph is going to give you buccolingual alignment, by which you can identify the exact position of the teeth. Okay, so that is called as a right angle technique. This is a part of your object localization. There is something called as object localization in your radiology. So one technique of object localization is right angle technique. Two exposures right angle to each other. The next one is, of course, most of you are familiar with, that is called as slop technique. What is slop? Same side lingual, opposite side buccal. So this is a slop technique. Okay, so this diagram based slop technique is a very familiar and a most common type of technique or type of question in your radiology. Okay, so what is this? This is a regular direct exposure. You have the lesion here, or you have the interest of focus here, And this is the mesial side, this is the distal side, this is the mesial side of the teeth, this is the distal side of the teeth. Right. So this is your area of focus. That is the second premolar area of focus. Okay. So what happens? The rays has been shifted to mesial side. Previously you have given direct, now it has been shifted to the mesial side. Similarly, your object of interest is here, it has been shifted to the mesial side. It has been shifted to the mesial side. So when you shift to the mesial side, the object of interest is also shifted to the mesial side, that is same side. As it is shifted on the same side, it is present on the lingual. For example, if you have shifted to the mesial side and the object of interest has moved to the distal side, and that is present on the opposite side, is going to be buccal side. So now this case is, this point is present on the lingual side because it is shifted to the same side. Okay, this is one more technique of slop. I just want to add a note because as we're talking to the slop, again, we may repeat this in your radiology. This is used in endodontics. This technique is called as Waltron's technique. And the deviation of angulation is 20 degrees. So when you have two canals in a root which are overlapped, you cannot see on the radiograph. So what you're going to do, you're going to change the angulation by 20 by which you can see the canals. It's most commonly used in endo. This is a type of slop technique, but the angulation is very specific. It is 20 that is used in the endodontics. To see the extra canal clear. Done. The next goes are few radiographic questions which are asked in the examination. I hope you're very familiar. Clearly seen dilaceration. Clearly seen like dancing teeth, dilacerated teeth. Okay. So dilacerated teeth sometimes on radiograph appears like this because this dilaceration is a mesodistal dilaceration. Means it is bended from here to here, mesodistal, which can be seen on a radiograph. This type of dilaceration is a buccolingual. So your buccolingual dilacerations can be seen as a scorpion teeth, or can be seen as a target lesion or a bull's lesion on an IOPA. See this buccolingually dilacerated. Okay, so they can ask you a diagram based question over this area. This is a scorpion teeth or a dilacerated teeth. The angulation in which they dilated is buccolingual. This is again called as a bull's teeth, which is seen on IOPA. Lingually impacted. Lingually impacted mandibular third molar will appears like a bull's eye. You can see a bull eye, right? So they can give you a radiograph. They can ask you like this. It's a lingually impacted mandibular third molar, a bull's eye. Okay, there are a few techniques that we have to make a note when we are talking about this. This is called as lateral trephination. This question was given in 2018 NEET examination. Question is very, very simple. Okay, so please do make a note of the scientist name for academic purpose. And when the paper setter is too rude, okay, they can ask you the scientist name. When the paper setter is extraordinary rude, they can ask you this technique was first invented in which year. All these are stupid questions which are out of globe. Okay, so I don't advise the student to remember the years. Not all years, but few years are important. Okay, so just try to move on. Like it's learning the subject is one of the parameter. Of course, we need to end up with a good rank also. That is also important. But please do make a note of the scientist name. And the type of incision that is used here is a modified S shape of incision. You can see a modified S shape of incision that is made from the retromolar fossa. Retromolar fossa crossing the external oblique ridge of the first molar. You can see the external oblique ridge and it is extended up to the first molar. Clearly seen that. And what you have to do is the buccal. You can see this. This is a buccal cortical plate. You have given some trephinations. Means trephinations is preparing a window, preparing an opening. Okay, prepare an opening. And this is a mode of like treatment when you have an abscesses in your dental structures also. Okay, which is a part of your endo. We'll learn in endo. Okay, this is a mode of treatment. Like you're going to keep holes and relieve the pressure so that the pus or abscess will drain and relieves. So your trephinations will be done on over third molar, and the burrs are used to prepare the vertical cuts anteriorly and posteriorly. You can see that vertical cuts, okay, anteriorly and posteriorly, and followed by the suturing technique. Okay, I hope you have, this is a mode of technique for extracting the mandibular third molar. Of course, again, this is a diagram based question, and it's a very complicated thing. That's the lingual split technique. So lingual split technique. Okay, so what is this lingual split technique? First of all, the important things that you have to make a note. The lingual split technique was first described by Sir Williams Fry. And of course, very important point, it is popularized by T. Ward. And this is a mode of technique which is useful for lingually impacted teeth. Lingually impacted mandibular third molar. Lingually impacted mandibular third molar. So the steps they can ask you as a sequence-based question in your INICET. And to understand, to have a better concept, it is better to learn the steps. Okay, I have clearly given the steps, the 8 steps of this technique. So initially, it's very simple. Like for every extracted teeth, you have to give a local anesthesia, and followed by you have to go for either Ward's technique of insertion, or modified Ward's technique of insertion. Okay, again, your Ward's technique and modified Ward's technique insertion are your most commonly asked diagram-based questions in your examination. So once you're done with the incision, then the next step is you need to create the vertical stops. So how these vertical stops, I mean, like this is a technique again which is done with mallet and chisel. Okay, so patients are very, very phobic, okay, by seeing that mallet and chisel. So this is a technique which is done by mallet and chisel. The first step is creating the vertical stops. So where these vertical stops are created, they are created distal to that of the second molar. So if you consider this as a third molar, you can draw a simple diagram. Let's make it as very simple. So you create a vertical stops. This is third. So this position will be occupied by second. So you create a vertical stops distal to that of the second molar. That's the first step. So once you are done with that, what you're going to do, you're going to convert a horizontal cut. You're going to convert a horizontal cut. So once you convert a horizontal cut, then you are going to extend like this. This is by keeping some trephinations. So this area is going to become weak. So that's the buccal area. It's going to become weak. So what you're going to do, you're going to remove the buccal plate. So first you're going to vertical stop. Second, you're going to give a horizontal stop. Third, you're going to keep some holes and you're going to cut the buccal plate. Okay. So by which you can get access to that other distal lingual bone, and where you, as the area is very, very thin, you can fracture the distal lingual plate. Okay, that is the lingual cortical plate, you can fracture it. So when you fracture this lingual cortical plate, you will have a wedge type of access to that of the roots, where you can keep the elevator, luxate the teeth and remove the teeth. Okay, and you can reposition the flap and keep a suture. Very simple techniques are vertical stops are given first, distal to that of the second molar, followed by vertical stop, a horizontal stop is given, keep holes, remove the buccal plate. Now you get access to that of the lingual plate. Okay, break the lingual plate. So you get access completely, you get a wedge type of access, keep the elevator, remove it. Keep the flaps back, suture it, topic is over, right? So they can ask you the steps, they can ask you the indications. Is useful for lingually impacted mandibular third molar, given by, popularized by, and the materials which are used. What are the materials used? Mallet and chisel are the things which are used. So they can ask you what are the advantages of this technique and disadvantages of this technique. So coming to the advantages of this technique, it's a very, very familiar question. Okay, so it's one of the fastest mode of removing the teeth, advantage. And the second one is there is less chances for causing damage to that of the inferior alveolar canal or the bundle of nerves which are present closely to that of the mandibular third molar. And third one, it reduces the risk of the blood clot formation, because mandibular third molars are the most common teeth, gives rise to dry socket. So dry socket formation can be reduced. and it decreases the damages to that of the adjacent periodontal ligaments of mandibular second molar. Okay, and it decreases the risk of healing problems. All these are the advantages when I'm talking about this split technique. The next goes the disadvantages. Okay, I just want to mention disadvantages. The disadvantages are the risk of damaging the lingual nerve is very high because it is lingually impacted and you are going to break the lingual cortical plate. So risk of damaging the lingual nerve is very high, whereas risk of preventing damage to the inferior alar nerve is a good aspect, whereas risk of damaging the lingual nerve is a bad aspect. And it also increases the risk of the post-operative infection, and the patient is discomfort because you use a chisel mallet, patient will feel discomfort, and this is regularly not a technique of choice in the case of young individuals because the bone is elastic bone. So elastic bone handling with chisel and mallet is a bad option. So one important aspect that I want to talk about the complications, like complications and everything, you can go for your regular mode of preparation, either with your basic MCQ books or your textbook based reading. Most of you are well familiar with this, that's more of common sense. So most of your questions will move on one of the peculiar thing that is called as dry socket. Okay, so what is this dry socket? So dry socket is one of the complications that you can see after the extraction. Okay, so they can ask you, dry socket is most commonly seen with which teeth? So dry socket is most commonly seen with mandibular third molars. How much incidence? 20%. The overall incidence of all the teeth for dry socket is 2%, and for mandibular teeth it is 20%. This question was given in the AIMS examination. Okay, so the overall incidence of dry socket is 2%, whereas particularly to the mandibular third molar, where dry socket is most common, is 20%. So 2%, 20% are an important area. So when dry socket, what are the etiology of occurrence of dry socket? So whenever you extract a mandibular third molar in a very traumatic way, without taking any precautions, there are high chances that the dry socket can occur. So what is the first one? Traumatic extraction. The second one is lack of proper irrigation. No irrigation. No irrigation, high chances of dry socket. The third one is you have to make a note about oral contraceptives. It's a very, very common thing. Okay, when you are planning for extraction, you should take all the medical information. So oral contraceptives, what they do is they increase the fibrinolytic activity. So the fibrinolytic activity, whenever your fibrinolytic activity increases, your blood clot is going to split, it's going to break, and it's going to release in the dry socket. So the patients or the women who are under oral contraceptives, increasing the fibrinolytic activity, releasing the breakdown of the blood clot which is formed in the socket, leads to dry socket. And the next one is hormonal changes. So during the menstrual cycle, all these hormonal changes again indirectly increase the fibrinolytic activity. The next one is the most common thing that we encounter in the clinical scenario is smoking. Most common in the males, smoke and the dry socket complaint. Or maybe any foreign body or any sort of thing which is left over while extraction. All these things are the primary etiologies for the occurrence of the dry socket. So what are the clinical features that you can see in the dry socket? You have to make a note. So dry socket is regularly seen after 3 to 4 days. 3 to 4 days. Delayed. It's a delayed problem. It's seen after 3 to 4 days. The patient complains of pain. The patient complains of abnormal odor in the mouth, that is halitosis, pungent taste or difference in the taste perception also. Other important thing that you have to make a note when I'm talking about 3 to 4 days is there is something called as delayed expansion. In your amalgam, the patient comes with a broken teeth after after amalgam filling, or patient complains of severe pain after 3 to 5 days. That is basically due to the delayed expansion. That is due to the zinc content. Zinc will show this delayed expansion by reacting with water and releasing the hydrogen gas. This hydrogen gas is going to cause the delayed expansion. And similarly, you have the same time duration, that is hypersensitive. So that is dry socket. 3 to 4 days or 3 to 5 days after the extraction, the patient comes back with the pain and change in the oral perception and halitosis. That is called as dry socket. And the next important thing that you have to make a note, sometimes the patient may complain of a fever, some systemic signs like fever, lymphadenopathy, and XYZ. And the first thing what you need to do is you need to take a radiograph of the socket and confirm that none of the root or none of the foreign body is left over. First, you need to take a radiograph. Okay. So the next important aspects of this are, you need to make a note about the theories of dry socket. Hope you are very familiar with the theories of dry socket. One theory is Brent's theory. It says about the fibrinolytic system. The fibrinolytic activity is also called as fibrinolytic theory. And the organism that is primarily responsible according to this theory is T. denticola. The second one is a different theory that is called as bacterial theory. And the bacteria responsible according to this theory are actinomycosis and Streptococcus mutans. So do make a note about the bacteria. T. denticola is again a regularly asked question. So these are the theories of dry socket. The next comes is the treatment. So already discussed, the first thing that you have to do is take a radiograph and rule out of the leftover root fragment or leftover foreign body. Then you have to go for irrigation. Good irrigation with the chlorhexidine. That is 0.12%. Make a note. 0.12% of chlorhexidine is used as a irrigation here in dry socket, and it is the same percentage that is used in the mouthwash. Whereas if you are talking about the irrigation in endodontics, chlorhexidine as an irrigation in endodontics, the answer is 2%. 2% chlorhexidine is used in irrigation of endodontics, and 0.12% chlorhexidine is used in the irrigation of dry socket. Okay. So apart from this, the other important thing that we regularly do in our departments when you see this dry socket case is good irrigation followed by Jedwoi paste. Okay. Or you can use metronidazole antibiotic paste or iodoform, which is soaked in the gauze. You're going to keep it along with the paste. And recently, few textbooks clearly says that you can use something called as PHBA, para hydroxy benzenoic acid, can also be used instead of your Jedwoi or metronidazole paste. So how this paste is used, they can ask you questions on this. First, this paste has to be changed for every 24 hours. Then you have to change for every alternative day. Then you have to change for every 3 to 4 days for 2 weeks. Right? First it is 24 hours. Then you can try it for every alternative day. Then 3 to 4 days you have to change it for about 2 weeks. So these are the treatment things that you have to do when you have seen a case of dry socket. So they can give you a simple clinical scenario. Okay, a patient went for an extraction of mandibular third molar and reported back with a severe pain and a malodor. And upon this, you have seen this. You can see this clinical feature, and they can give you a history of smoking or a woman of using under the medication of oral contraceptives. So, what is the possible diagnosis and what is the treatment plan? Can be a case limit question. Okay, so major content of Exodontia is done, and few other things we'll be discussing on our daily activity on the group. Okay, so it's very important for each and every one of you as you go into the preparation phase. At every point, at every day, at every exam, at every level, you have to question yourself. Am I doing good? Yes, I'm doing good. So at every point of your preparation, whether it's a daily examination, whether it's a topic specific exam, whether it's a class or a topic or a subject, you have to review yourself at every point, that how far you are and how far you are up to. So if you do this, this is going to create a cumulative effect on the end product. So that's going to be on the final exam. All the best. Signing off, Dr. Srikanth from Team MDS CONQUER.